Recording. Assalamu alaikum wa rahmatullah, everyone. My name is Muaaz Anwar. I'm a second year medical student. Today, with my colleague Ibrahim, we'll be going through pulmonology physiology practice questions. So, I've divided this PPT into topical wise. So, we'll be going through topic wise. If you have questions at any point of the lecture, feel free to let me know, and I'll do my best to explain to you guys. And other than that, I have checkpoints in the lecture between it, and you can ask questions there as well if you want me to go behind or anything. So let's begin the lecture or the practice questions. So this is the first question. Which of the following structures is involved in both air conduction and gas exchange? So what do you think the answer is? How do I open chat? Yep, you're correct. The answer is C. And I'll go through the explanation for this because I think this is very important to know. So, oops. Okay. So you have branchings of your airway. You begin from your trachea and it divides into bronchi, which divides multiple times until it forms bronchioles and it forms terminal bronchioles. And this is what's known as a conducting zone. After the terminal bronchioles, you form the respiratory bronchioles, alveolar ducts, and alveolar sacs. Now, why does the conducting zone portion not conduct air? Not perform gas exchange. This is because the trachea, bronchi, bronchioles, and terminal bronchioles are very thick. They have thick walls with smooth muscles, which are very thick, so air cannot pass through there. They're this thick because they want to bear the force of the air, which comes through these airways. And after that, once you pass this conducting zone, you have the respiratory zone. The special thing about this is that they have something known as type 1 pneumocytes or type 1 alveolar cells, which are responsible for forming a very thin membrane around this in order to allow gas exchange to happen. So the respiratory bronchioles is a special thing. It contains portions of the conducting zone and the portions of the respiratory zone. So it's a transitional point. Since it's a transitional point, it has some smooth muscles which are now thinned, so they aren't as thick as they were in the conducting zone, and they're thin, and they start to have these type 1 pneumocytes, thus forming an alveolar membrane there, a thin one. So this is why the answer of this question is C. And another thing which I want you guys to know, because he might change the question somehow or one way or another, is that this conducting zone is also known as the dead space because this is the zone which only conducts air. There's no gas exchange happening here, so they named it as dead space. Basically, there's no gas exchange which happens there, so they just named it as dead space. And then you have this alveolar space, which basically is where the gas exchange happens, and therefore it's known as the alveolar space. So normally your tidal volume, which as you guys know is the normal breathing, quiet breathing of 500 milliliters, it goes through this dead space and 150 milliliters of that is going to remain here and the rest of the 350 milliliters is going to go down and then go into the pulmonary vessels. And this branching from the conducting zone, from the trachea till terminal bronchioles, you have generations from generation 1 till generation 16. That's 16 generations of branching, and the respiratory zone consists of branching from 17th to 23rd generation. So he might ask you which, instead of like asking which structures are involved, which generations are involved in gas exchange. So it would be from generation 17 to generation 23. So this is what I wanted to know. And in special conditions such as like pneumothorax or any other diseases, you might have more of your alveolar space which is damaged, and thus it cannot conduct air. So in those cases, you would say that you would finally calculate the physiological dead space, which would be defined as a volume of lungs that does not participate in gas exchange. So in all conditions, physiological dead space is always going to be greater than anatomical dead space, or is going to be equal to it. Never is it going to be lower. So he might ask you all these three types of questions in a way related to this. So that's why I added all of them. Moving on to the next question. During normal respiration, dust and carbon particles that reach the alveoli are removed by which of the followings? Yep, you're right. The answer is C, alveolar macrophages. This is a pretty simple question and it feels histology, but Dr. Shams actually loves to put a question about this, and it's even in one of those quizzes which he sent, and those quizzes are very high yield. So he might ask you about type 2 pneumocytes instead, and you know that type pneumocytes are the ones which form surfactants. Then he might ask about Clara cells instead, which form a surfactant-like substance. So he might ask you any question like this, but he loves to put this question like this. I've seen it in all the batch papers, and I remember doing it as well. So it's important to know what each of these things do. And moving to the next slide. A 28-year-old athlete is undergoing a pulmonary function test before joining a diving program. During quiet breathing, the technician instructs him to relax and breathe normally through the mouthpiece. As he exhales normally and pauses before taking his next breath in, this parameter measures the lung volume at that point. At which phase of respiration is this lung volume, the functional residual capacity, achieved? Yep, you're right. The answer is D. So Dr. Shams loves to complicate things, so he might just give you a complicated case scenario like this, but the answer is really going to be simple and the question is going to be really simple. So they're asking, basically the question is asking, when is the functional residual capacity? And the case is describing he exhaled normally and then he paused. So at exhaling normally and quiet breathing, these are both relating to tidal volume. So he exhaled his tidal volume and now he's reached his FRC, which is the residual capacity. And this exhaling normally is the normal expiration. So this was his slides as well. It's very important to know what each of these things are. Residual volume is 1.5 liters, and yes, it's very important to know each of these liters as well. Residual volume is 1.5 liters. It's always going to remain in the lungs to keep the air patent. You have the expiratory reserve volume, which is also 1.5 liters, and you can exhale it. Once you exhale it, there's a keyword, maximal exhalation, which is for expiratory reserve volume. Then you have the tidal volume. Its keyword is right here. Quiet breathing is the normal breathing up till 500 milliliters. And finally, you have the inspiratory reserve volume, which is the maximal inhalation you can do, which is around 2 to 2.5 liters. And I've written them in words here as well, if you want to go through it. And the FRC, which the question was asking here, is the residual volume plus the expiratory reserve volume. So it's basically the phase before normal breathing. Okay, next question. A 45-year-old man with no history of lung disease is asked to perform a helium dilution test. He was connected to a 1.5 liters bag containing 12% concentration of helium and was told to rapidly breathe until the concentration in the bag and the lungs are the same. If the final helium concentration is 6% and the patient was at residual volume when connected to the bag, what is his residual volume in liters? Okay, so one of you guys have said that the answer is F, and this is why I put this question. Normally, once you calculate this, you would get F, but the answer is C. Yep, that's correct. The answer is C, 1.5 liters. And I'll explain to you right here. I'll calculate it with you guys and let you know why. So normally, what this question is asking you guys is to perform a helium dilution test, and the formula is really simple. Instead of complicating it, I will just go through the simple formula, which is what we even did in high school. Concentration 1 times volume 1 is equal to concentration 2 times volume 2. So here they've given us volume 1, which is 1.5 liters. They've given us concentration 1, which is 12%. But for 12% in these calculations, you put it into decimals. So 12% would be equal to 0.12%. So concentration 1 is 0.12%. And similarly, they've given us concentration 2 right here, which is 6%. So it would be 0.06. And the volume is unknown. So this is what we have to find. And we'll be taking it as x. So once we calculate this, 1.5 times 0.12 is equal to 0.06 times x, we would basically get x is equal to 3 liters, which is what one of you guys chose the answer as. However, the question is asked, first of all, the question told us he was told to rapidly breathe until the concentration in the bag and the lungs are equal. Then they told us to find his residual volume in liters. So what you actually found, this 3 liters, is the volume of his lungs and the volume of his bag, both of them. So 3 liters is the total volume. But since they're asking us to find his residual volume in liters, we have to subtract the volume in the bag from the total volume. Because he was breathing until there was equal volume and concentration in his lungs and in the bag, this means that the volume is equal. And therefore, the volume which we found using this formula is 3 liters. Normally in the formula in V2, they add as the volume of bag plus the volume in his lungs. But since we need the volume only in his lungs, we're going to subtract 1.5 from 3, and that will give us 1.5 liters as the answer. So if they're asking residual volume, the answer is 1.5 liters. But if they were to ask the total volume of air, then that would be 3 liters. So this is also a high yield question, which I remember him asking us about it, and I also got confused when I was doing it the first time. So that's why I was like, I need to add this question. I hope this was clear. And let's move on to the next question then. Oh, they added in your TBL as well. Yeah, that it's very high yield. I'm sure even if they added in your TBL, it might be in the SAQ or the MCQ as well. Each one of them. He loves putting calculation question, especially in SAQ. All right, let's move on to the next question. So this question is saying a 65-year-old man with no history of lung disease undergoes spirometry during a routine checkup. Compared with his results at age 25, his total lung capacity remains nearly unchanged, but his residual volume has significantly increased. Which of the following best explains the change in his measured vital capacity? Yep, as you guys are all correct. The answer is B. So to explain this question, I have this graph from Dr. Shams's table. It's very important to know all of these. What happened is that as you get older, you basically can think of it as an artificial emphysema. So what happens is that the elastic muscles of those of people who are above 60 years old, they lose some of their elasticity. So what happened is that they can't recall well, but it's not as severe as emphysema. That's why I said artificial. It's easy to remember it that way. So what happened is that they're gonna breathe instead of breathing the 500 milliliters their FRC being at 3 liters, what's going to happen is that their normal breathing of 500 milliliters might be at 700 milliliters, for example, and it might go to 3.7 liters. But once they're exhaling, because they have less force to exhale the air out, what's going to happen is instead of going all the way back to 3 liters, it might go to 3.5 liters. What's going to happen by this increase is going to remain constant in 3.5, so the FRC might move from 3 liters to 3.75. This would mean that the residual volume has moved up from like 500 milliliters to like 750 milliliters, for example. And this would mean that the expiratory reserve volume has also moved up, maybe all the way at the middle of this thing. So that would mean that the patient's ability to inhale is going to decrease because his total lung capacity has remained the same. As long as the total lung capacity remains unchanged, that means he can't breathe more than what his limit is. So his baseline air has increased, but his limit has remained the same. This means that his ability to inhale has decreased. So this is what happens in people who have gotten older. Their vital capacity is going to decrease, but the residual volume will increase. So you guys did correct, mashallah. Let's move on to the next question. So this is the first checkpoint. If you have guys and have any questions, let me know and I'll go back and explain to you as best as I can. Okay, let's move on then. So this is the next topic, lung mechanics, P18 and 19. So this is the first question. A 34-year-old man undergoing a pulmonary test takes a deep breath as told by his doctor. The compliance of the respiratory system changes as the lung volume changes. At which lung volume of lung capacity does the respiratory system have the highest compliance? C and A. Okay, so this question is a confusing question, and the answer is A, not C, and I'll explain to you guys why. So if you look closely at this graph, A is the point in which his normal breathing, tidal volume, quiet breathing. B is the phase when he's doing inspiratory capacity. So he's breathing, inhaling up till maximum which he can. And at this point, it's going down. So the point of the C is going all the way down up till his exhaled residual volume and then going back up. So actually the C point, it's talking about more like the volume after uh, expiration, maximal expiration. Meanwhile, what A is, they're talking about the point of FRC. What this means by the highest compliance is that they want you guys to know at which point does this patient have the highest compliance. And as we know that the point of highest compliance is that they want to go to their resting volume or the FRC. So another thing to note is that the values, most of the time, if the patient is said to be normal, the volume for FRC is always going to be 3 liters. So if you see at the C option, they're saying that it's right after maximal exhalation, and his lungs, they haven't gone to 3 liters point. Which is basically not at our FRC. And another thing to note, if that is abnormal, is that he's just finished exhaling and he hasn't exactly reached the point in which he's normal and going to inhale again. So the answer is going to be A, and this is his point of FRC, which is 3 liters. I hope that was clear. So FRC, yes, A is the FRC point here at this patient. C, yes, it is, but in this graph specifically, because he is exhaling completely, what happens is that at this point, it said that he hasn't reached the potential in which his lungs are back to normal. So this is the point after maximal expiration instead of being the point after normal expiration because he's went all the way. A is not the exhalation. That's normal inspiration. So A is the point basically at FRC. One thing is because of 3 liters, and the thing is why the C isn't it? Because this is at normal inspiration, but C point is talking about maximal expiration. So the patient has just finished maximal expiration instead of normal expiration. So you guys are talking about normal expiration, which would be true if the point was ending right here. This is the most optimum FRC, basically, which is going to have the highest compliance at. More than FRC, it's best to say where in which point does he have the highest compliance in. So FRCC can also count as an FRC, but since they're asking about highest compliance, at this point, he has just finished the maximal expiration. Compared to the point in which is the normal inspiration, this is going to count as the actual point of highest compliance. Because comparing normal inspiration with maximal expiration, your lungs have basically just exhaled everything compared to when it's normal. So at this point, it's going to have the highest compliance in contrast with point C, in which you have just finished maximal expiration. FRC, yes, FRC is functional residual capacity. Yeah, it can be FRC, I guess. My bad for saying that. It would be point of highest compliance. That is way more accurate. It's my fault. C is the point of less compliance, and A is the point of higher compliance. C would be the more accurate version to say FRC. That was my bad. Sorry about that, guys. I hope this is clear. Okay, that's good to hear. Alhamdulillah. Okay, let's move on to the next question. So if you got this exam, do put no. If they're asking about highest compliance, you're supposed to put A. But if they ask you FRC, you're supposed to put C. Since the question is asking at which lung volume of lung capacity does the respiratory system have the highest compliance? Yep. Okay. I hope that's clear. Sorry for the confusion. My bad. Let's move on to the next question then. Yeah, this was another explanation about this question. Instead of asking a question like this, because I took the most complicated version of this question, he might just ask you what's the formula to find the compliance of the respiratory system or lungs. So this is the formula you're going to use. It might just come as an MCQ just for this. And this is basically what I wanted to explain to you by telling you maximal inspiration is restricted by the lung, maximal expiration is restricted by the chest wall. This is because the normal FRC or the resting point of the chest wall is right here, the red dotted line and the blue circle there, which is approximately 5 liters. And the resting point for the lungs is below residual volume, which is at like 300 milliliters. I think it's best to know that this is 300 milliliters. And what happened is that you have something known as intrapleural pressure. It's going to act as a gluing force. It's going to glue the chest wall to the lungs, forming the resting volume of the respiratory system. By gluing these two systems together, it's going to put it into an equilibrium, and therefore it's going to bring the resting point of the system as a whole to around 3 liters. Individually, chest wall is greater at approximately 60% total lung capacity, and the lung volume is around 300 milliliters. So the intrapleural pressure is going to act as glue, bringing it to the FRC. This is also important to know because he can ask a question like this. I have a question about this later on, but I decided to explain to you guys a bit here and then a bit more in the next question. So this is the next question. A patient suffering a bilateral pneumothorax is taken into the ER where the doctors need to assess the amounts of air entering his pleural cavity. What two volumes can they use? B, yes, all of you are correct. MashaAllah, the answer is B. So to go for this explanation, the previous slide is also here to more explain. What happens in pneumothorax is that his air is going to enter his lungs. Since this is a case of bilateral pneumothorax, air is going to enter both of his lungs. Since they enter both of these lungs, what's going to happen is that the pleural pressure, which keeps the chest wall and the lung glued together, is going to disappear. Since it disappears, the chest wall is going to want to move to its functional residual capacity or resting volume. Every system always wants to move to their resting volume because that is their most optimum state. So in bilateral pneumothorax, air is going to enter, it's going to get rid of this intrapleural pressure, then it's going to remove this gluing force on the chest wall and lungs, and the systems are going to go through individual FRC. This is going to cause the patient's alveoli to shunt. No more air is going to pass through, and if not treated, they will die because they cannot breathe. What happened in this is that since the lungs have shunted, the alveoli have shunted, there's no air passing, you can no longer calculate functional residual capacity. And all of the other options are talking about functional residual capacity. So the answer is going to be B, the resting volume of the chest wall, which is this, and the resting volume of the lung, which is this, since both of them are going back to their original resting volume since the gluing force is gone. Okay, so I hope that was clear. The lungs tend to recall inwards. The lungs tend to recall inwards, and the chest tend to recall outwards. And as mentioned here, because you see the chest wall resting volume or the functional residual capacity is around 5 liters. And normally your lungs is at 3 liters. So what's going to happen is that since the gluing force is gone, the chest wall is going to recall outwards to its functional residual capacity, which is at 5 liters, and the lungs is going to recall inwards from all the way 3 liters to 300 milliliters inwards. So that's why the lungs are going to recall inwards and the chest wall is going to recall outwards. And I've written it here as well. Your lungs and chest wall always want to be at the resting state, but because of the intrapleural pressure, they're glued at an equilibrium, which is 3 liters. And he might change the question as well, just asking you in words, where is the resting volume of the lungs? So you should know that it's below residual capacity. This is also the reason if it's not treated, the patient is not treated, he's going to die because his airway is no longer patent. And he might just ask about the resting volume of the chest wall in birds as well, which is 60% of total lung capacity. So I hope that's clear. And yeah, that's good to hear. Alhamdulillah. Let's move on to the next question. So the next question, which of the following lung volumes or capacities cannot be measured by using a spirometer? Yep, you guys are all correct. The answer is D. This is because when you use a spirometer, you guys know how it works. You connect a mouthpiece, there's a mouthpiece in your mouth, and you connect it with a bag or anything which has air inside. So whatever you do when you're breathing in or breathing out, it's going to be through that mouthpiece. So whatever goes through the mouthpiece or from the mouthpiece to your mouth, those are the only volumes which can be calculated using a spirometer. So in this case, the expiratory reserve volume is going to be exhaled through the mouthpiece. It can be calculated. The inspiratory reserve volume, it can be inhaled through the mouthpiece, so it can be calculated. That the volume is the same, it can be exhaled or inhaled through the mouthpiece, so it can be calculated. But total lung capacity, it cannot be inhaled or exhaled, specifically the residual volume component. Total lung capacity consists of the residual volume, expiratory reserve volume, inspiratory reserve volume, basically everything. But the residual volume, as even mentioned in the previous question, is going to remain in the lungs to keep the airways open or patent so that air can pass through. So the residual volume is never going to leave your lungs unless you have a condition, abnormal condition. And therefore, by extension, you cannot calculate total lung capacity. So yes, the answer is D. Oh, sorry. So I hope that's clear. Let's move on to the next question then. Okay. A man had mild bronchitis, which developed into lung emphysema. Which of the following best describes the man's lung volume? Yep. MashaAllah, you guys are very smart, MashaAllah. The answer is B. So this question is talking about mild bronchitis and lung emphysema, which is an obstructive pulmonary disease. So the main word difference between restrictive and obstructive is that in obstructive disease, you have problems in exhaling. So your exhalation is obstructive, and in restrictive, your inhalation is restricted. So in this question, since he has emphysema, his obstruction is going to be restricted. Restricted obstruction means that he can't exhale as he wants to because he has a blockage there. That means instead of exhaling all the 500 milliliters of his tidal volume, he might just exhale 250 milliliters of his tidal volume. What that's going to cause is that his the air in his lungs is going to move from being at normally at 3 liters to 3.5 liters. It's basically the same question as the old man. You can think of it that way. So the air in his lungs is going to increase as the baseline. So his total lung capacity is the same. That's going to mean that he can inhale a lot less more. So this would mean that his residual volume increases. By extension, his FRC is going to increase since FRC is residual volume and expiratory reserve volume. And vital capacity is going to decrease because vital capacity is the capacity of the person to inhale at their maximum. So the answer is B. And this was relating to the graph. So every single graph of Dr. Shams's slide is very important. It might come in OSPI. It's going to come in OSPI actually, and it might come in SEQ, and it's 100% going to come in SAQ. The TL total lung capacity increase, it might increase just because he can inhale a lot. So it might go all the way till 9. So as you can see here in this graph, compared to the normal, his TLC is higher. So this is capping at like 7 liters, for example. But in a normal person, you're below 6 liters approximately in this graph, or at 6 liters exactly. What happens in emphysema is that you can inhale a lot more than normal. So you don't want to inhale that much, but you might just inhale that much. So it causes your total lung capacity to increase more than normal. And in emphysema, what's going to happen is that your recoil force is going to decrease. This relationship is inversely proportional. So as your compliance increases, your recoil is going to decrease. And the formula for transmural pressure is a lot important. I put it in 3 slides, but it's not that much important in this slide. So it will talk about in the other questions. So the vital capacity, it decreases because let me just go to the, yeah, okay. So what happened is that his residual volume and FRC, as you understand, increased. So the air in his lungs normally went from 3 liters to all the way to 3.25 liters. What's going to happen is that since his baseline has increased, I should have added that slide there. Since his baseline has increased till, for example, it increased till here, take this as 3.5 liters. But before he had emphysema, his baseline to breathe was from here at 3 liters exactly. So he was able to inhale from the point of 3 liters up till point of 7 liters, for example. But since he developed emphysema, he's having trouble exhaling all the air outside. His baseline went from 3 liters to 3.5 liters. But his total lung capacity doesn't increase that much because unless he maximally inhales, which is like beyond maximal inhalation. So his baseline moved from 3 liters to 3.5 liters. So just by looking at this graph, you would know that his ability to inhale went from 3 liters to 7 liters to only 3.5 liters to 7 liters. So his vital capacity or the ability to inhale has decreased. I hope that was clear. So that's good, alhamdulillah. No worries, anytime. You can ask me any question at any time. Okay, moving on to the next question. A 65-year-old man with long history of smoking presents with progressive shortness of breath. Pulmonary function testing shows an increase in total lung capacity and a marked reduction in elastic tissue within the alveolar walls. The lungs are easily distended but show poor elastic recoil, leading to air trapping and hyperinflation. If instead a disease process caused an increased elastic recoil of the lungs, what would happen to the lung compliance? Yep, you guys are right. The answer is B, decreases. Because while it's the case scenario is talking about lung emphysema, the question is asking about lung fibrosis, for example, a restrictive disease. You might just give you a question like this. I think I kind of remember getting a question like this, and I had to do it in my second try because I didn't read it properly. So in this question, they're asking about restrictive lung disease. And in restrictive lung disease, which is the third graph here, lung fibrosis, what happens is that your ability to inhale drastically reduces. So if you are to breathe like 3 liters every time, you might only breathe 1 liter now. So that would mean that the compliance decreases because compliance is the ability to fill up your lungs with air. And since your ability to inhale has decreased, you aren't able to breathe as much, so your lung compliance has decreased. And this is the main difference between fibrosis and emphysema. It's important to know that in emphysema, compliance increases, recall decreases. Meanwhile, it's the opposite in fibrosis. So you can just remember one of them, and you just need to know that the opposite is for the other. Another thing which you can remember it how is that emphysema is going to obstruct your exhalation, while fibrosis is going to restrict your inhalation. So one stops exhalation, one stops inhalation. So I hope that was clear. Let's move on to the next question. This is basically inversely proportional relationship between the elastic recall and compliance. So this is the second checkpoint. If you guys have any questions, you can let me know. I'll try to help you. Okay, that's good to hear, alhamdulillah. So let's move on. So this is the third topic, airway resistance. There's going to be smooth sailing from now. There's not much, so let's go ahead. A 40-year-old healthy man performs a series of deep breathing maneuvers for a pulmonary physiology study. When he takes a maximal inspiration to total lung capacity, his alveoli become greatly distended, compressing the capillaries running between them. At which lung volume would the alveolar capillary vessels have their highest resistance to blood flow? A, yes, the answer is A. And this question is basically asking about the question is basically asking about alveolar capillary vessels. So this was a slide from Dr. Shams's first lecture, and I thought it'd be really good to put this here. So imagine your lungs are totally filled with air. You can see the vessels inside the alveoli basically going to supply them with air. So if your lungs are greatly distended, it's going to compress all of these blue vessels, and this compression is going to lead to a reduced radius, which is going to increase in pressure. This increase in pressure, which means that there's highest resistance because they're trying to keep themselves patent. So you know from your cardio as well, the formula is like 1 over R4. So radius, as soon as radius decreases the pressure or the resistance is going to increase. So the answer is A. But on the other hand, if they were to ask you about extra alveolar vessels instead, the answer would be residual capacity. Because whilst the lung volume and is directly proportional to the pressure in alveolar vessels, the lung volume is indirectly proportional to the pressure in the extra alveolar vessels. So you might ask you any of these two questions, and I also remember him asking these questions last year, so I decided to add this question here as well. Okay, moving on to the next question. So we have a 58-year-old man with long history of smoking, presenting with shortness of breath and wheezing. Pulmonary examination reveals prolonged expiration and diffuse wheezes. Spirometry confirms an obstructive pattern with increased airway resistance. Which of the following interventions would decrease his airway resistance and improve airflow? Yep, correct, mashallah. The answer is A. So administering beta 2 agonists, it sounds very complicated. So let's just make it in simple words. Beta 2 agonists, administering them basically means activating the sympathetic nervous system. Now, you guys know that normally when the sympathetic nervous system is activated, it's going to constrict your vessels and everything most of the time. And the parasympathetic system is going to relax them. But in medicine, there's nothing absolute. So once the parasympathetic sympathetic activity happens in the lung, instead of constricting the vessels there, or the airway there, it's going to dilate the airway instead. So it's going to be the opposite. Administering beta 2 agonist is basically the same as saying activating sympathetic activity at the airway. And instead of constricting them, it's going to dilate. So the simulating parasympathetic activity is going to relax your muscles and stuff, but once it comes to the airway, it's going to constrict them. So simulating parasympathetic activity and inhibiting sympathetic activity is the same. So the answer is A, and no would be correct as well. I guess so, yeah, because it's going to dilate your airway as well, I believe. I think so, yeah. But I'll confirm it and let you guys know, but I'm pretty sure nitric oxide will do the same as well for this. Yeah, no worries. Okay, moving on to the next question. And yeah, we are at the last topic, second last topic, I believe, assessing pulmonary function. So, a man with emphysema is exhaling with pursed lips. How does this help him in inhalation? D. Increase in transmural pressure. Yes, all of you are correct. The answer is D. Increase in airway transmural pressure. So this was a slide from Dr. Shams's slides, and I'm not going to talk about the values because I feel like it might confuse you guys more. I'll just talk about the general concepts. So I've written here, if transmural pressure is greater than zero, airway is patent. If transmural pressure is less than zero, airway collapses. Transmural pressure is equal to pressure inside minus pressure outside. So normally what happens in emphysema is that you create an obstruction outside your airways approximately, preventing you from exhaling properly. So if you were to do, sorry, this obstruction, it causes an increase in pressure here. So that would mean that the pressure outside would get more greater than the pressure inside much faster. And therefore you can't exhale everything. But once you do this pursed lips maneuver, what happens is that you make an kind of like obstructive force further inside the airways instead of like further outside the airways. So because of this new pressure formed inside the airways, the transmural pressure is going to increase. This means that, for example, this was like 40 here and this was 20 here. It's going to cause the transmural pressure difference to get to zero much later. So because of this pursed lip, you have an extra force here. It's going to increase the pressure more inside, and it's going to delay the moment when transmural pressure gets less than zero. And this causes the airway to remain patent for a longer period of time. I hope this was clear. This is a bit complicated. I've explained well. So, okay, let's move on to the next question then. So, which graph is indicative of a restrictive disease? C. C. Yep, you guys are all correct. The answer is C. The graphs of Dr. Shams are really, really very important. He might bring you all of these graphs, maybe in SAQ, maybe in MCQ multiple times. So this is why I put a lot of these graphs. The first graph describes you the normal graph. The B is describing you obstructive pulmonary disease, and the C is describing you the restrictive disease. So the thing which you want to look at, first of all, they're talking about FEV1. This is forced expiratory volume in 1 second. So how much volume is this guy exhaling in 1 second? Normally, it's like, as you can see here, it's like 3 liters, 4 liters approximately. But once you move on to obstructive pulmonary disease, you see in 1 second, he barely exhaled anything compared to normal. So this tells you that there's a problem in this guy when he's exhaling. So you know, when problems with exhaling is related to obstructive disease. If you look at C, you see that his FEV1 is approximately the same because you know that you have increased recall but less compliance. So you would have problems in inhaling, but in a graph like this, where they're talking about exhalation, is going to have almost the same exhalation as that, with obviously less exhalation, but it's going to be like that, similar to the normal one. So yes, the answer is C. Mm, yeah. Okay, moving on to the next question. Oh, this was basically the table which he wants you to remember. It's important to know that the FEV1 to FVC ratio, instead of asking like a graph like this, he might as well just ask you some values like compared to a obstructive pulmonary normal person, what happens to the FEV1 to FVC ratio in an obstructive pulmonary disease? So you need to know that this it decreases, but in restricted lung disease, it either remains the same or it increases to like 90%. So he might ask you in words instead of giving you the graph. Okay, I hope that's clear. Let's move on to the next question. Which graph is, uh, thank you so much. Okay, which graph is indicative of an obstructive disease? So what graph do you think is the answer? Red, red. Yep, you guys are correct. The red graph shows you the obstructive pulmonary disease. Now, in this kind of graph, you need to look at their beginning, specifically the FEV1, which is the forced expiratory volume in 1 second. If you were to look at the maximal value, you would always go to like 8 liters, 6 liters. You'd be like, it looks the same, somewhat like that. The end volume is the same. But you need to look at 1 second, how much air is expelled. So if you look at 1 second approximately, which is here, air is expelled for the blue one approximately 2.3 liters. For obstructive, it's approximately 4.5 liters. And for the normal, it's approximately like 5.7 liters, something like that. So by simpler words, you know that the least air exhaled should be restrictive because you can't inhale so much in restrictive because you have problems inhaling. And by extension, even though you have greater recall force, since you don't even have much air to inhale, you can't exhale as much. So in restrictive disease, all volumes are proportionally decreased. And for this obstructive one, as red one, you see, even though because you have greater compliance, you can inhale a lot. And compared to normal, you have decreased exhalation. So this is what I wanted to know the FEV1, how the graph looks from here, instead of like till 8 seconds or something, because you might get confused. But in obstructive, isn't there a problem? Yes, there is a problem in exhalation. That's completely correct. But what happens in restrictive lung diseases is that all volumes are proportionally decreased. So what happens is that you have a huge blockage once you're inhaling. So it's going to restrict your inhaling. Normally, a person is going to breathe 3 liters. In obstructive, because of increased compliance, he might breathe till 5 liters. But what happens in restrictive, he can't even breathe 3 liters, for example. He might just breathe like 2 liters. He's not able to breathe even once he puts more force. But if he puts more force, as in this example, if he puts more force in this example, it's stopped moving. Okay, if he puts more force, as in this example, he might be able to breathe 4 liters or 3.5 liters, but he can only exhale that much. In emphysema, he might breathe to like 9 liters, but only 4 liters can be exhaled. Okay, that's good. Alhamdulillah. If you have any other questions, let me know. Okay, I hope then this is clear. This is another table of Dr. Shams's slide, but I don't think you really need to know any of these. Just know what they mean, but you don't need to remember them. The most important thing is the FEV1 to FVC ratio. You need to know in restrictive, it either remains the same or it increases, and in obstructive, it decreases. And obstructive pulmonary disease are chronic bronchitis, emphysema, asthma, and restrictive is only pulmonary fibrosis. Okay, we're at the last topic and the last question from my side. So this is a question from my friend. So it's a kind of a hard one. So a 32-year-old, yes, yeah, I think do you have any question? Yeah, I think it might have been a mistake. Okay, so a 32-year-old female with claustrophobia, fear of closed spaces, is stuck in a malfunctioning elevator. She experiences severe anxiety as well as dizziness, weakness, and blurred vision. Which of the following is the most likely cause of this patient's symptoms? Okay. Any others? Okay. Okay, so the answer of this question is C. Yep. The answer is C, you're correct. And A and B are wrong. I'll explain to you guys why it's wrong. So the patient is said to have claustrophobia, which means because she's in a malfunctioning elevator. She's having dizziness, weakness, and blurred vision because she's having a severe anxiety attack. So a severe anxiety means she's going to start hyperventilating. She's going to breathe very rapidly. Now, there's a misconception sometimes that hyperventilating means that she's breathing oxygen at a very fast rate. However, hyperventilation or hypoventilation is related to carbon dioxide. So this patient or this female has claustrophobia, severe anxiety. She's hyperventilating. This means that she's at a rapid pace. She's exhaling carbon dioxide. She's breathing out carbon dioxide at an increased pace. Since she's breathing carbon dioxide out at an increased pace, that means that the CO2 tension decreases. And since she's hyperventilating, that means the oxygen is increasing as well, but it's not really going inside the pulmonary vessels as much because she's exhaling at a faster rate. The carbon dioxide is leaving, and the oxygen is staying there and going to the pulmonary vessels. So arterial partial oxygen is not going to increase. Sorry, it's not going to decrease. It's going to increase because she's hyperventilating. Oxygen is going inside. And the hyperventilating is going to cause the carbon dioxide to leave at a very fast rate and is going to cause the pH to decrease. What was the other one for B? Arterial oxygen content. It's not going to be as much because once she's hyperventilating, the carbon dioxide is leaving at a faster rate and the oxygen can't diffuse so much inside. Yep, hyperoxia hypocapnic. Yep, because her oxygen is increasing. So instead of being decreased arterial oxygen content, it's going to be increased arterial oxygen content. But oxygen is going to be directly decreasing because it's going to leave at a faster rate. As your friend said, hypocapnic. Sorry, hypercapnic. Yeah, hypocapnic. Yeah, hyperoxic, hypocapnic. Yep, that's correct. Okay, so that's it from my side. Now it's my partner, Ibrahim's turn. I hope I was able to answer your questions and make all the concepts clear. Inshallah, the exam is easy and may Allah help you guys. Good luck in your exam. Assalamu alaikum.
Yes, all right. It's nice to meet you guys. Just before we get started, do you guys want to break like a good 5 minutes, or do you guys want to just go and finish the lecture? Let's go for it. It's fine by me. I'll wait for one more answer. I think people already took their break. Okay, let's continue. Sure, خلاص, we'll continue. So, assalamu alaikum, everybody. My name is Ibrahim Alodhaibi. I am a intern, and I am very excited to be teaching you guys my first PAL session for this year. It's been a while since I've done one of these. So thank you to Muaaz for the amazing work he did for the previous lectures. And now let's continue. So at any point, if you guys have any questions, feel free to unmute and ask. Feel free to type in the chat. If I miss something, let me know. And Bismillah, here we go. So we're going to continue off in the same sort of pattern, which is going through lecture by lecture. So question number 1. When oxygen moves through the thin side of the blood gas barrier from the alveolar gas to the hemoglobin of the red blood cell, it traverses which of the following layers in order? Now, this is a basic recall question, but also something important for you guys to know. So let's see what you guys can do. It takes a while to read the options. All right, A. A. All right, good job. Yes, so the answer is A. So the layers that the oxygen is going to be transversing through is the epithelium, the tissue interstitium, the capillary endothelium, plasma layer, red cell membrane, red cell cytoplasm, gas binding to hemoglobin. Is this clinically relevant stuff? Not necessarily, but this is a question that could be easily asked on your guys' final as a basic recall question. All right. Moving on to question number 2. So in the hemoglobin oxygen dissociation curve shown below, The shift from curve A to curve B could be caused by which of the following? Okay, I'm seeing some answers. All right, so correct. Good job, you guys. The answer is C. So we're having a shift from to the right here, which means that we are actually having less oxygen or an incomplete transfer of oxygen. Now, in their lecture, it actually says that exercise increases the recruitment and distension of pulmonary capillaries, which causes a better matching of blood flow and ventilation, essentially leading to more oxygenation. However, the option for the previous question said strenuous exercise. And what's important to note here is that increased cardiac output during exercise will recruit the pulmonary capillaries and cause for better ventilation and perfusion. However, when we have an increased cardiac output at a very extreme sense, we're shortening the amount of time that the blood or the oxygen is able to actually saturate the blood, thus leading to decreased oxygenation on the hemoglobin curve. So it's important to remember to think that through in a question like this. While some things, like while exercise may initially increase it, it can decrease it. And it's easy to make a trickier question with that. So everyone's all clear on that. We're ready to move on. Other factors also to keep in mind are body position. Supine increases the distribution of blood, and we're going to talk about that more when discussing how gravity is going to affect the pulmonary vasculature, as well as body size. Bigger lungs means bigger surface area. All right. Let's move on to our next question. So this is a calculation question, so it's going to might take you guys a second. So we have a 35-year-old man. I did not even start reading the question. Someone already answered. We have a 35-year-old man who was admitted to the ER with suspected overdose of heroin. He was referred to the pulmonary function lab for conducting spirometry and measurement of diffusing capacity. The partial pressure of carbon monoxide, or PCO, in alveolar gas was 0.5, and the CO uptake rate equal to 20 per minute. What is the CO diffusing capacity of the patient? All right, so I'm going to give the other students a little bit more time to calculate this and come up with an answer. All right. Mashallah. Great job, you guys. So yes, the answer to this question is B. It is 40. Can someone actually tell me the equation that they used to get the answer here? Yes. All right, great job, you guys. So yes, here is the arguably the worst part of CVP, in my opinion, is the abundance of calculations that you guys have to do. So any of the calculations discussed in pulmonary physiology and also in the cardiology sections are free game for you guys to be tested on in this exam. And there is a lot of them. So really make sure that you guys are taking your time to actually also, when is your guys' exam? Just as a side note, but make sure that you guys are taking the time to sit down and actually understand all of these equations and how to calculate them, because the questions in 3 days, well, بالتوفيق للجميع. Inshallah, you guys will all do great. Make sure that you take the time to understand all of these equations because they can be asked in a plethora of ways and they can make up a lot of unique questions following them. So our previous question, we were trying to find the diffusion capacity of carbon monoxide, and we were given the values 20 and 0.5. So we need to remember that the ventilation, or the equation is ventilation divided by PaCO, or 20 divided by 0.5, which gave us the answer of 40. This diagram is taken from your guys' slides or Dr. Sham's slides explaining this process. So this was a fairly straightforward calculation question where the values were given to you right away and you were able to just plug them into your equation. Sometimes that might not be the case. When we get towards the end of the lecture, I have created a document for all of you guys that has all of the calculations across all of CVP, including cardiology, that you guys can refer to when doing practice questions, just so that you can get more familiar with all of the equations if you're not already. Anyways, just to be clear, everyone understands how we got to 40 here. You guys ready to move on? All right, great. So when a person is standing, blood flow in the lungs is which of the following? Okay, all the answers are coming in. So correct. So when a person is standing, blood flow is highest at the base because that is where the difference between arterial and venous pressure is greatest. Again, another more of a recall question, but I really wanted to make sure that you guys are understanding um, this stuff because the basis of CVP physiology, particularly pulmonary physiology, is you guys understanding what is happening exactly. And then once you're able to understand it, you can think your way through most of the other questions. So this is again a diagram taken from your lecture of the distribution of perfusion in a lung in an upright position. So as I mentioned previously, the distribution of blood flow is affected by gravity. Thus meaning that blood flow is going to be highest at the base of the lung, or as we can see here, zone 3, where the arterial hydrostatic pressure is going to be the greatest, and also the difference between the arterial and venous pressure is also the greatest. This will drive a difference in the blood flow between the bottom of the lung and the top of the lung. So just remember that there is a gravitational effect, and we're going to talk about more about the perfusion and ventilation as we go on through the lectures. But keep in mind that the base of the lung is the most perfused, or yeah, is the most perfused. Next question. What happens to pulmonary vascular resistance in the presence of alveolar hypoxia? Okay. All right, I'm seeing some answers. Oh, any more? Any more takers for the question before we move on or before we reveal the answer? Okay. So correct to the people who did answer, the answer is B. It increases. So this is a very, very, very important concept that you guys need to understand. My video and stuff is clear, right? I just want to make sure that you all can hear me. Yeah, okay. So this is a very, very important concept when it comes to hypoxia. So when alveolar ventilation is decreased, our lungs have the ability to do this thing called hypoxic vasoconstriction. So everywhere else in the body, this occurs as the opposite, where hypoxia is going to cause vasodilation and an attempt to get more blood moving around. However, when alveolar ventilation is decreased, our lungs are going to do the opposite and do something called hypoxic vasoconstriction, which basically is an attempt to redirect the blood from the areas that are not being ventilated with oxygen to areas that are going to be ventilated from oxygen. Remember, the blood's main goal, besides, perfusing the lung, is to pick up the oxygen and lead it to the rest of the tissues and the organs in the body. So if there's an area of the lung that is not being ventilated and not receiving oxygen for any reason, whether that be disease, whether that be blockage somewhere, the body does not want the blood to flow there because it's not gaining anything, and thus will vasoconstrict those areas and redirect the blood to another area. I can't emphasize how important this concept is, just in general, not only for this exam, but just in general. You need to understand that this is happening and that it is different from everywhere else in the body. Muaaz also put a question about beta 2 agonists. It's not important for you guys to completely understand what those are and how those work, but you should know that beta 2 agonists act to dilate in this context. Moving on to our next question or our next lecture, we're going to be talking about blood class transport. A 38-year-old woman moves with her family from New York City to Leadville, Colorado, which is 10,200 feet above sea level. Which of the following will occur as a result of residing at a high altitude? All right. Great job, you guys. Yes, that is correct. There will be a shift to the right of a hemoglobin oxygen dissociation curve. And I want to sit down and discuss the hemoglobin oxygen dissociation curve for a while with you guys because it is very important. And also, there are many ways to ask questions about this. So, can someone just quickly tell me what does it mean when we say a shift to the right? What does that mean for the hemoglobin oxygen dissociation curve? Decreased affinity. Right, correct. Okay. So now I have another bonus question for you guys. Can somebody type or unmute and tell me what are the factors that do affect the oxygen hemoglobin oxygen dissociation curve? It's a mouthful. But what are the things that can affect it? So we have pH, that's correct. We have temperature, yes, 2,3 BPG. All right. Yes, CO2. Yes. Okay, so you guys got it. So over here we have a table showing the different things that affect it. I highly, I'm emphasizing to you guys, stick this graph to your memory. There is at least, I mean, like, look at it. There's 1, 2, 3, 4, like there's at least 8 to 9 ways that they can ask a question just about the direction that they think could shift. And that's only if they're asking it directly. It may also be asked in a more, different way. But no, it's very important that you guys memorize this graph and have it understood well, because there are a lot of ways that they can ask you. And I guarantee that on this exam, you are going to get a question about the oxygen hemoglobin dissociation curve. So make sure that you understand it well. To talk about the previous questions in regards to the shift in the higher altitudes. So when we're at a higher altitude, the partial pressure of oxygen in the alveolar air is decreased because there is basically decreased oxygen in the atmosphere. This is going to cause hypoxemia, which is going to lead to hyperventilation. All right. This is going to trigger some chemoreceptors in your body and which we're going to discuss later on when we talked about controller bleeding. Once that hyperventilation triggers, we're going to have something called respiratory alkalosis. As a response to that, 2,3 BPG levels are going to increase, which is going to bind to the hemoglobin and cause it to shift to the right to improve the loading of oxygen in the tissues. Essentially, this 2,3 BPG is going to actually, where's the pointer options? Here we go. All right. So this is basically attaching itself to the hemoglobin, making it easier for the oxygen to be released into the tissues. Because while you're in an atmosphere that has less oxygen, your body is prioritizing getting that little oxygen that you are breathing to the tissues so that they can carry out their function. If we have hyperventilation and decreased carbon, wouldn't that also shift to the left since carbon shifts to the right? So if we have hyperventilation and decreased carbon, wouldn't... Yeah, okay. So yes and no at the same time. And let me explain what I mean by that. Well, what I mean is that initially, yes, this could happen, but the way that increased altitude works in the human body is that eventually the body is going to adapt to it. So the hyperventilation is not actually going to stay present for a long time. This is something that's transiently happening up until the 2,3 BPG is being produced in the body, and our body starts basically correcting itself in the higher altitude. So the hyperventilation is going to do a lot of things to the just initially stepping into high altitude is going to do a lot of things for the hemoglobin oxygen dissociation curve. But the main takeaway from this is that the 2,3 BPG is going to eventually adapt the body to release the oxygen that you're taking in to the tissues. Does that make sense? Do you get what I mean? All right. Basically, the main idea is that it is going to adapt eventually. All right, let's move on to our next question. So, at the same PCO2, venous blood will contain more CO2 than arterial blood. Which of the following effects or laws is responsible for this? Okay, I'm seeing some answers. I'm glad I brought in this question. All right. So the answer to this question is B. It is the Haldane effect. And we were going to discuss the difference between the Bohr and the Haldane effect. It's important for you guys to memorize. I keep saying it's important, but I mean, this is an exam. So make sure that you guys are able to differentiate between all of the effects and laws. There are lots in CVP. Just to be clear, Patamon effect is not a real thing. That is an option I made up and put into this question. So if you're not recognizing what that is okay. Patamon is a Digimon. I just needed an option to put into this question. But yeah, the answer for this is Haldane's effect. So let's discuss what is the difference between the Bohr effect and the Haldane effect. So they are easy to get mixed up. Let's talk about the Bohr effect first. So as hydrogen changes, the O2 affinity changes because hydrogen ions are going to rewind reversibly to the hemoglobin. So as we discussed with the oxygen hemoglobin dissociation curve, high amounts of hydrogen ions are going to shift the equilibrium to the left, while shift it to the right, while low amounts are going to shift it to the left. What is this doing? It's basically assisting oxygen loading inside of the lungs as well as oxygen unloading into the capillaries. The Haldane effect is discussing CO2 instead of hydrogen. So deoxygenated hemoglobin, meaning hemoglobin after it's unloaded or all of its oxygen or before it has loaded any oxygen, can bind more carbon dioxide than oxygenated hemoglobin can. So thus, the unloading of O2 in peripheral capillaries. So when the hemoglobin gets rid of its oxygen, it is able to facilitate the loading of carbon dioxide. This effect facilitates CO2 loading in the tissue capillaries and unloading in the lungs. Now, I know those last two bullet points for each side can come off as a little confusing, but you guys will get these slides, and I really encourage you to just sit down. If you're struggling with this, sit down and read it over and over again. So you're able to differentiate that the Bohr effect is focusing on oxygen loading in the lungs and unloading to the body, while the Haldane effect is focusing on loading CO2 and unloading it in the lungs. All right. So are we all clear with the Bohr and the Haldane effect and not mixing up? You're most likely going to get a question on one of these two topics. So it's important that you guys are able to differentiate between them and also all of the other laws. All right, moving on to our next question. We're on our next topics, which are hypoxemia and VQ mismatch. So question number one. So compared with the apex of the lung, the base of the lung has which of the following? MashaAllah, Asad, you're answering these very quickly. Great preparation. All right. Yes. So the answer is B, a higher pulmonary capillary PCO2. And so we're gonna discuss this for a while. The distribution of ventilation and perfusion in the lung. So we already talked about perfusion previously and how gravity affects it, etc. But ventilation, perfusion, and the distribution of that is very, very important because it creates this unique ratio that is that can be asked about in a bunch of ways and also just very clinically important. So as we know, and as seen in this diagram, ventilation and perfusion of the lungs are not distributed evenly. So they are both the lowest at the apex and they are the highest at the base. But the differences for ventilation are not as great for perfusion. So let's look at this diagram here. We can see that the perfusion at the apex of the lung is very, very low. All right. But the perfusion or the ventilation is a bit higher. It is less than it would be at the base, but it is a bit higher. All right. This causes a ratio to be formed where it is higher at the apex and lower at the base. As a result, gas exchange is more efficient at the apex and less efficient at the base. All right. So therefore, blood leaving the apex is going to have a higher PO2 and a lower PCO2 because it is better equilibrated with alveolar air. All right. So what does that mean? And this confused me a lot personally in first year, and also I graduated medical school, and this still confused me when I was preparing it for you guys. Look at it. Look at the arrows over here. So we have ventilation and we have perfusion, right? There is less blood to be perfused at the apex of the lung, right? And we're having more ventilation than we are having perfusion at the apex of the lung, which means there is less blood to have to load oxygen onto at the apex of the lung compared to the base of the lung, which is why we're saying here blood leaving the apex is going to have a higher PO2 and a lower PCO2 because it's better equilibrated with alveolar air. We are able to feed the perfusion coming to the apex of the lung with more air easier because there's less perfusion and more ventilation. Does that make sense? Do you guys do you guys like have you did you wrap your head around what the VQ equilibrium is and why that? Okay, great. This is a very, very important concept. That's why I'm sitting here and spending time on it. Um, you need to be able to understand this because another way that a million questions can be asked is the VQ. All right. Here's another question. So the arterial PO2 and arterial PCO2 from 5 how is ventilation higher at base when compliance is lower? How is ventilation higher at base when compliance is lower? So at the base of the lung, right, we have to talk about how the alveoli are stretched out more, which means they're able to accommodate more ventilation. So think of it in the sense of the alveoli when we're talking about ventilation. When we're reaching the base of the lung, the alveoli are stretched out more, which means that more oxygen is being delivered to them, which means that they are receiving more ventilation. Does that make sense? And then when we think about perfusion, just think about it in terms of gravity. All right. So, which of the following patients is most likely hyperventilating? Hypoventilating, not hyperventilating. All right. So I see some answers. All right, let's move on. So correct, yes, it's patient E. Um, I'm glad that you guys understand what hypoventilating is. This is the question that would have honestly tricked me when I was in first year. But yes, hypoventilation. So remember, let's make sure that we have the full picture. The respective values for normal ventilation. So PA for the alveoli, the PaO2 is around 100, while the alveolar CO2 is around 40. However, the normal pressures for the arterial perfusion for PaO2 is around 90, and for PaCO2 is around 45. Now, I don't want you guys to stick the arterial perfusion numbers in your head like as fact, as in like it's got to be 90 or it's got to be 45. These values can have a range, right? So with hypoventilation, the alveolar ventilation is going to decrease, which is leading to a decrease in the arterial O2 below a value of 80. Because ventilation is reduced and an increase in because ventilation is reduced, there's an increase in PaCO2, which is above 45. More CO2 is being retained, which explains why for our patient or for our question here, patient 5 is the patient that is hypoventilating. His arterial PO2 is 70 and his PCO2 is being more retained. Um, yeah, I have the question up. It's important. Again, this was the reason why I put this question is that I want you guys to be able to differentiate between the alveolar values and the arterial values. It's easy to get messed up in a question when you're thinking about the alveolar um, oxygen or CO2. Make sure that you read every single question very, very well on your exam on Wednesday because they love tricking you. They love tricking students, and it's easy to fall into those traps. But remember that this is the values for hypoventilating. This question could easily come as a hyperventilation question, and our values could be swapped. Um, but that's for this question. Are we clear on it? Are we ready to move on? Any questions? Yes, clear. All right, let's keep going. So which of the following combinations of alveolar ventilation and pulmonary perfusion will produce the highest arterial PO2? I'll let you guys sit with this one for a bit. Okay, so this one Just tricking you guys. All right. It is confusing. Yes, it is confusing. Maybe, I couldn't let you guys all get all of my questions that easy. No, I had to put in a few hard ones. So yes, the answer to this question is F, where I believe who is this? Hussein. You had the right idea here. This is the highest VQ ratio. So we're again talking about the VQ ratio here, where we're looking at the ventilation and the perfusion. And that takes us back to this same exact diagram where that concept I explained of ventilation being increased in an area where perfusion is decreased is going to lead to a higher arterial P or higher arterial O2. All right. And that's because there is essentially less blood to perfuse with oxygen, which means that the ventilation is able to saturate the blood with oxygen that is coming through because there is more than enough oxygen to go around to put into the blood. That's the way I like to think about it. Is that the most scientific and medically accurate way? Not necessarily, but it helps me understand it, and I hope it helps you guys understand it. But do we all get why, um, for this question, F would be the answer? Because this creates the highest VQ ratio. All right, so I wanna. Is that at the apex? Yeah, this is at the apex of the lung. The highest ratio is at the apex, yes. So you thought because having both increased is ideal. I mean, yes, you have a point in real life. Like, oh yes, this would be ideal. We're having more perfusion and we're having more oxygen. That should be great. But this question is specifically asking about which of the following is going to cause the highest arterial PO2, and what is going to trigger the highest arterial PO2 is having the highest VQ ratio. And of all the options here, the thing that is going to cause the highest VQ ratio is F. Do you get why? Yeah, okay, cool. All right, next. This is our actually, I think this is our last question. We're breezing through these. So this is control of breathing. Um, so which of the following is an expiratory accessory muscle? I had to throw this in here. It's just a recall question, but it's a question that I think I would have gotten wrong in first year. So I needed to keep it in. Okay, you guys know your anatomy. You guys are reading the slides. Yes, correct. The answer is internal intercostals. Here is just quickly refresher. The expiratory accessory muscles are the abdominal muscles and the internal intercostal muscles. The inspiratory consists of the scalene, the sternocleidomastoid, the trapezius, and the external intercostal. Don't try to there's not much more to look into this. It's just this is a recall question, and you are going to get a couple of basic recall questions in this exam, like the few that I showed before. Just keep it, know this, right? Here's another diagram of just the muscles to those visual learners who might want to see them. And let's move on to our next question. Which of the following is responsible for terminating inhalation and initiating exhalation? Okay, so this one you guys got right away. I'm glad that you guys are studying this lecture well. This is another one of those things where a lot of questions could be asked from one place. So yes, the slow acting stretch receptor the slow acting stretch receptors are the things responsible for that. And again, here's a screenshot from your slide. So high activity or high lung volume is going to inhibit further inspiration because we're not going to be able to take in any more oxygen. Thereby, we're going to be turning inspiration off and starting expiration. This reflex is called the Herring-Brewer reflex. Keep that name in the back of your mind just in case they decide to throw it at you at the exam so you're not lost when you see it. All right. These receptors are also activated if there's a lack of movement, such as holding your breath, or of deflation of the lungs less than FRC, right? So the Herring-Brewer reflex, which is controlled by these slowly adapting stretch receptors, is known as both an inspiratory terminating and an expiratory terminating reflex. Now, I brought the slow-acting stretch receptors because they tend to ask about them pretty frequently in the exam. However, they can really ask about any of the things that they mentioned in this lecture here. And there is a lot of actually, let me say this now while you guys are still focusing with me. There is a lot of detail in the control of breathing lecture in terms of like where things are located anatomically, Just a lot of detail, and I feel like it could have gotten overwhelming if maybe you didn't feel overwhelming, but personally, even as I was reading it, as someone who literally graduated medicine, there was stuff I was understanding for the first time reading that lecture again, like 6 years later. All right. So make sure that you're sitting down and really looking at practice questions and seeing what they're commonly asked about, because it's very easy to get lost in all of the details. All right. But they tend to ask about this, the other receptors, particularly their function and what role they're meant to carry out is all free game to be asked. Don't worry too much about the history of them, where exactly they're located, like those minor details. It's easy to get lost in those. Don't fret yourself with these. So this is our very last question. So we have a 40-year-old man who is receiving mechanical ventilation in the ICU after admission for severe respiratory failure. The ventilator settings include a tidal volume of 600 ml and a respiratory rate of 15. The patient is in a deep coma and cannot increase his total ventilation beyond what the ventilator is set to deliver. On his fifth hospital day, he develops high fevers and is determined to have a new bloodstream infection. Which of the following changes would be expected as a result of this patient or of this change in the patient's condition? This is a much harder question, honestly, but I felt the need to include it. Oh, F is not an option. F is part of E. The breath is not just a. Okay, so we have C, C. Okay, thank you for saying that, Zaid. We'll talk about how to approach this question logically. All right, so you guys are right. The answer is C, and we're gonna explain it, and then I'll talk about the approach to these questions, because you will get a lot of clinical scenarios kind of like this. So, arterial PCO2 is related to the ratio of CO2 production and alveolar ventilation. So, with a fever and a bloodstream infection, CO2 production is going to increase, and it should increase. But looking at the way that this question was asked, this patient was on a ventilator, which means his minimum ventilation was fixed. He cannot raise his ventilation to compensate for the increase in CO2 production. And thus, as a result, this PCO2 will um, increase. Okay, so essentially, more CO2 is being produced in this body, but because this guy is on a fixed ventilator, which is an important detail part of that question, he is unable to compensate for it. Thus, arterial PCO2 will increase. All right, so do we understand why the answer for that question was C before I get into how to approach this question? Okay, yes, okay, I'm glad. So, when you get a question like this at this level or of this amount of text, basically, it's just a wall of text. It can be really super overwhelming. Okay, there are a few important things that you guys need to look for at your level in first year. Really, my advice would be look for the things that you recognize. Okay, because there's so many easy terms to just throw into a question that makes it seem more and more confusing. Well, I don't know what this means, and I don't know what like oh, he develops high fevers and he has a bloodstream infection. Like, what is that supposed to like? It don't. A lot of this is just filler. Okay, the important parts of this question, okay, is that this patient, even his tidal volume and his respiratory, all of that stuff is irrelevant. The only thing that you need to take away from this question is that the patient is in a deep coma and he cannot increase his total ventilation beyond what the ventilator is set to deliver. That is literally the main takeaway from this question. And then you go and read the rest of the question. Okay. Sometimes they're going to put in a very key detail for in between a bunch of slop. Okay. And so you have to be able to do as many practice questions as possible so that you guys can build the skill to see how can I approach a question, how can I extract from a scenario what's actually necessary for me to do and what's not. With that, we've come to the end of this lecture. Thank you guys for being so interactive. My contact information is here. The feedback is in the top right. And then also, as I mentioned earlier, I have created a PDF file of all of the equations for every single calculation that could come on this exam. So if Yes. Noor, once I wrap up, we can chat a bit more about other things. So also I have a favor for you guys to ask. So for this PDF, could you guys please scan it, share it with your batch? I think it would be very helpful. Um, my advice would just put these equations as quickly as you can in your short-term memory so that you can write them down right before you start the exam and have them and not have to think about them later. With that, if anyone has any questions regarding anything, I will stick around and answer, whether that be about the exam or just anything medical school related in general. If you're watching the video on YouTube, my contact information is also here. Um, and you can reach out to me at any point regarding anything. I've been through all of the things that you guys are about to go through, so I know how it feels. Um, Thank you, and that's all. That's all I have to say. I'll stick around for a couple of minutes for any questions, and that's it.